The first discussion this morning will be on Stephen King's Carrie. Let's all agree that we're going to start with the eponymous character, the protagonist, antagonist, Carrie White. First question is, what did you see? What did you see that you thought made this particular case intriguing?
Yeah, so I think right off the bat, when I was looking at this film, I wanted to recognize what leads to a person being in a particular situation. So I think we should start with the overly religious mother and what that had on her, what that did to her conscience.
So from a behavioral perspective, how would you, as a clinician, describe Carrie's relationship with her mother?
I think that, well, first, I think I'd like to draw a distinction between like religion as a pathology and somebody who has a delusion, right? So I think like calling her religion or her overly religious anything is like not really totally appropriate. But I think that the relationship between the mother and the daughter is such that the mother is like definitely super controlling.
Super controlling.
And kind of like she has like Carrie has no say in her own life at all whatsoever.
Right.
Yeah.
So, with regard to this relationship, what I'm hearing, correct me if I'm wrong,
Yeah.
what I'm hearing is that the mother is over-controlling. The vehicle that she uses to over-control her daughter happens to be religion.
Exactly.
And this relationship certainly might be identified as a clinician, as a psychiatrist, as clinically significant. That is, if Carrie presented to any one of us for a psychiatric evaluation, it would be very hard and difficult for us to dismiss this relationship that she has with her mother. I think Carrie would likely self-report this. And if we ever had Mrs. White come into our meeting, I think that would be a very robust and straightforward observation that there's definitely a dynamic going on here that is very maladaptive.
Yes.
All right, so we certainly have some potential etiology for something.
Mm-hmm.
What's that something? What are aspects of Carrie White's behavior that, as a clinician, we may be concerned about?
I was initially wondering if she had like some sort of social anxiety disorder versus like just like an avoidance kind of trait. I don't know that I'd call it a personality disorder, but she has like avoidance traits, and certainly she has social anxiety, which like I would too if I grew up in my house. But I don't know. That's kind of where I was thinking along those lines.
Social anxiety, rule out social anxiety disorder, two different things. For social anxiety, and therefore for social anxiety disorder, I want to remind the medical students especially that when you take your shelf exam, you have to be very, very careful on how you approach questions. This goes for board certifying exams as well. How you're going to approach the anxiety disorder questions. Because if you take a peek at answers A, B, C, and D, and they all contain anxiety disorders, you should very quickly be reminded that the way to approach this question is unlike the way you would approach any other question on a standardized exam. And the reason why is because when you read through a question and then you peek at the answers to then get a hint about what it is the test writer, the exam writer is asking, you are going to put yourself in a situation where you are very, very likely to be confused. And the reason why is because the anxiety disorders have way too many common overlapping signs and symptoms. So that trick, the test-taking technique, does not work here. And it could actually backfire on you because you could go through answer A, not definitively rule it out, answer B, think that that might be the right answer, C, same, and now you're 30 seconds later and you still haven't made any inroads to what the single best answer is. There is a way to get around this. right? So this is a major test-taking strategy. It's a little different than usual. I want you to be able to list all the anxiety disorders prior to your exam, like that. If you can do that, you are half the way there. If you're driving to your exam, or if you're taking it remotely, and you can't do that, you will be behind that proverbial 8 ball. You need to be able to do that. Not pertaining to this particular didactic, but we will have a didactic where I will give you an acronym, where you going through those anxiety disorders will be very simple. You will be able to memorize them and list them quickly. We'll talk about that. Once you're able to do that, you need to review every single anxiety disorder and pick out the one salient feature that readily differentiates it from the others. And then you look for that feature in that clinical vignette, get your answer, you move on. That's the way to tackle anxiety disorder questions on standardized exams. One example here would be this idea of social anxiety, which might have a component of avoidance behavior. That might be choice A. What may be choice C is a condition called agoraphobia. Also, unfortunately, anxiety disorder, that too, TOO, is demonstrative through avoidance behavior. So all of a sudden, in reading question or answers, A and B, now you're scratching your head. So what is it then that you need to go back to the clinical vignette, specifically look for to differentiate social anxiety from agoraphobia? Because both will present with avoidance behavior.
Yeah, I think you need to look and see, like, is the patient afraid to leave her house? Does she avoid leaving her house? And that's not true for Carrie.
So Carrie does not appear to be afraid to leave her house.
Yeah, she wanted to go to the prom.
Why isn't she afflicted with agoraphobia that she is pushing through? Remember, it's not only avoidance, but in aspects where she is not avoiding, she is undertaking, in this case, going to school with significant stress. But that may still be due to avoidance. So the answer here is the question, why? Why is Carrie avoiding? For agoraphobia, the individual avoids so as to avoid a situation in which they may become symptomatic. And escape from the social situation may be difficult or embarrassing. Right? This often, not always, but often is due to a co-occurring condition, which may be psychiatric, medical, or neurological. Tourette's, irritable bowel. That is agoraphobia. Social anxiety disorder, often referred to as social phobia, presents the same way with avoidance behavior. However, the motivation behind that avoidance behavior is different, and therefore distinguishes social anxiety disorder from agoraphobia. In social anxiety disorder, the avoidance is due to the fear of embarrassment of the social situation or performance situation itself. And a very common example, perhaps the most common example, would be public speaking, which is why in 2013, the American Psychiatric Association made performance type an actual qualifier. Here's the test question. Right, now that you know what you know, here's the test question. A faculty member at a prestigious medical school in New Jersey presents to you for anxiety as a chief complaint. They tell you that they have a fear of getting behind the podium when they have to speak in, let's call it, an East lecture hall that is filled to capacity. You ask them, what is the fear, right? That's what a psychiatrist has to actually ask. What is the fear? They tell you that because that door immediately to their left is usually locked, in the event of their becoming symptomatic, escape is going to be impossible without embarrassing myself. Single best diagnosis. Right? It's agoraphobia. right? It's agoraphobia despite the fact that I created the venue of public speaking. What the fear is will define the anxiety disorder. Are either of these in play for Carrie? So I'm hearing unlikely. This is only me playing psychiatrist, but the pause leads me to believe that you are not overwhelmingly convinced that Carrie's avoidance behavior is due to either agoraphobia or social anxiety disorder. One more example, separation anxiety disorder, which is a maladaptive form of separation anxiety, which itself is a normal anxiety when age appropriate. So when an individual is about 18 months and they separate from the primary caregiver, they're going to experience anxiety. Children that young usually do not present to their pediatrician verbalizing, "I am anxious." They instead cry, and that happens. And if primary caregiver took that child to a pediatrician and thought there was something wrong, they're going to get reassured that this is age-appropriate social anxiety. I'm sorry, separation anxiety, which is exactly what it sounds like, separation from primary caregiver. That's okay for the 2-year-old. When the same symptoms occur in a 22-year-old, we would not consider that to be normal development. And hence, now separation anxiety disorder must be the single best answer. A couple of red flags on your standardized test. Number one, this will usually 75% of the time present as a child, although not at the age of 2, more around 9-ish, right? So a child, yes, because previously it was not found in the anxiety disorders chapter, but instead in the child adolescent chapter. And even though it's since been moved out 2013 DSM-5, the fact is that it's usually a child that still presents on standardized exams with exacerbations of anxiety. Children, behavioral, children, somatic, right? In terms of how they express anxiety. What you will need to look at with regard to the facts in the clinical vignette that will allow you to choose separation anxiety disorder as your single best answer include less about where they are going to invoke the anxiety and more about where they are separating from. And one very common way a question writer does that is they give you multiple venues. So when the individual is going to school, they act out. They have tantrums. When the individual is going to play practice, they act out. They throw tantrums. When the individual has a sleepover, birthday party to go to, they have anxiety, stomachache. It is very unlikely that each of those venues is causing the anxiety when the common denominator appears to be where they're separating from. So, not that it's a slam dunk given, but separation anxiety disorder should be at the top of your differential, and then when you actually talk to the person, when you talk to the child, and you understand their fear, maybe their report will further support the idea that it's where they're separating from that's invoking this anxiety. So again, they're just examples of how these anxiety disorder questions can appear very similar on an exam avoidance behavior. Yet if you know what to look for, especially on an exam, they're easily differentiated. So you're going to get your single best answer. Separation anxiety disorder may be playing a role in Carrie White's behavior. Right? I want you to keep this one in the back of your mind. Right? Beyond that, anything else with regard to Carrie?
Trauma from the blood incident, but I think it could be presumed that this isn't the first time she's been bullied horrifically by classmates and peers. So I think we might be seeing some sort of PTSD or a trauma-induced reaction to social environments, which hasn't been dealt with or is reinforced by her mother's, the way her mother deals with things. So I think that might be in play.
I agree. The clinical perception that what we see was likely not the initial trauma. It's something that the clinician should always delve into. Right? When you uncover a trauma, be careful to waste any time patting yourself on the back. Always go back further. Right? Now, you do it in a very non-judgmental way, non-confrontative way, but you do it. Right? There might be trauma here. And this is where, if you're watching movies through a psychiatrist's lens, we begin to watch this film in a very different way. Very similar to how when a person talks to us in a hospital as part of a history and physical, we are actively listening in a very different way as compared to how we might actually talk to people outside of a hospital, family and friends. In this case, with regard to the film, we have to be very careful and look at this particular character and the relationships she may or may not have had with people in the film, as well as those who are not. This is when we begin to actively watch the film and notice that there are certain characters not written in the script. A normal person would shrug their shoulders and think no big deal. A medical student rotating through their core psychiatry clerkship does not appreciate a movie like that. In medicine, we call that a pertinent negative. Who is not in this movie?
Father.
Biological father. And it isn't that it's irrelevant, it's highly relevant because mom's behavior has everything to do with his not being in this movie. So it isn't something I think any clinician would think to dismiss. And his not being in the script, I think, is very consistent with your observation that there may have been a prior trauma, because these two may actually merge. Keep that in the back of our minds too. Post-traumatic stress disorder, acute stress disorder, two other disorders that in fact may present with avoidance behavior. Now imagine that, an anxiety disorder on your shelf, and all of a sudden, separation anxiety, agoraphobia, social anxiety disorder, PTSD, and even answer E, acute stress disorder, all present with avoidance behavior. So, again, really underscoring the importance of A, knowing these personality disorders by name in a list, and B, knowing what quality is specific to one, therefore differentiating it from the others. You adjust my mask again. The mask is not playing fairly. Okay, that works. All right. Anything else with Karen?
I think she might have, I think if we look at her as a pediatric patient, I think there's definitely developmental milestones that were missed. I think that could be presumed.
I agree with you. Unfortunately, given my background or lack thereof,
Yeah.
I can't delve real deep into that, but yes. What I will say is that maybe not in the initial psych assessment, but certainly in follow-up, her past psychiatric and developmental history is something we definitely need to understand better. I 100% agree with you there. Any other thoughts? Who wants to play Sigmund Freud for a little bit? The fun stuff in psychiatry, all right? So we're gonna have to you guys in a flashback now, talking about PTSD, to your freshman year in college, introduction to psychology courses. And let's talk about the relevance of Sigmund Freud in 2020. One perspective of what might be going on with everything we just discussed is the psychoanalytic perspective. And along these lines, when we talk about trauma, we have to think that this character, Carrie White, might be at risk for specific or particular mental disorders. Those trauma disorders start with post-traumatic stress, but in our differential, we would of course think depression. We should think of the borderline personality with regard to sexual trauma, early childhood sexual trauma. Dissociative disorders, and boy, does this character dissociate. And when she dissociates, really bad things happen. I mean, pyrokinesis, telekinesis. These may be very symbolic about her inner state, if you choose to watch this movie, again, through the lens of a psychiatrist. And then finally, eating disorders, early childhood sexual trauma. What about Sigmund and Freud support the idea that Carrie, the film, may be a fictional case study about eating disorder? So again, I guess a different way to restate this is, per Sigmund Freud, per the psychoanalytic theory, what causes eating disorder? Remember, eating disorders, like any mental disorders, etiology, biopsychosocial. We're just choosing to focus on the psychological factors within that biopsychosocial model. And more specifically, with regard to psychological factors, the theory of psychology we're choosing to delve into here is analytic theory. That's Sigmund Freud.
Is it an issue with oral fixation that leads to eating disorders? I'm just trying to remember.
Yeah.
I can't fully.
So, very quickly, we think that something happened. I'm going to piggyback what was already talked about with regard to trauma, and perhaps regression to the oral phase, which is about 1 to 2 years of age. Right? Sensory neural, as per Piaget. Basic trust versus mistrust versus per Erik Erikson. So I mean, these all match up, depending on which theory you want to go with. We're going to stick with Freud. Okay? So there is regression here, and the oral phase would be a concern. That means if you are really engaging Carrie White in psychotherapy, that is something you're probably going to have to process. That is not to mean that she should be part of a didactic like ours, where we bring this up and we teach her, and then she leaves in an hour cured. Far from it. You know, we're talking psychotherapy 5 days a week over months, if not years. The other part of this therapy would focus, per Freud, on Carrie having an impulse, part of her id, that is striving for conscious expression and awareness, but is being thwarted, like all of our impulses, being thwarted by our superego, a second component of our subconscious. For individuals who struggle with eating disorder, per Freud, that impulse is that I want to kill my mother. And it's largely driven by the over-enmeshed mother dynamic that we've already identified. Intrusive. Carrie struggles with that. Children do have fantasies about killing their parents. It's an id impulse. And in a lot of ways, it's natural. We never do it. Most don't do it because of an intact superego. However, it causes conflict. Any impulse that rises for conscious awareness or expression that is considered taboo, too threatening to think about, is going to be thwarted by the superego, which acts on the reality principle. That dynamic, the id versus the superego, creates friction, and Freud put a name to that friction, called it anxiety. So the question then is, for anxiety, when people have these taboo impulses, which we all do, we can never express because of an intact superego. Why is it that we're able to sit around the table, listen to this guy for way too much, way too long, and not be reaching for your benzodiazepine? The answer is you have ego strength. There's a third and final component of your subconscious whose primary focus is to alleviate that anxiety caused by the friction between the id and the superego. And the way the ego does this is through ego defense mechanisms, subconscious processes that alleviate anxiety. And there are several, dozens perhaps. Some work better than others in some situations. The problem arises, however, when an individual only has one go-to. Because when they have one go-to, it's not a one-size-fits-all. So they're going to run into a situation in which they will reach clinical significance. It's rigidity, not flexibility. When an individual has one go-to, it begins to define their behavior, and therefore it begins to define who they are. And that includes disorders like eating disorder. The defense mechanism that Sigmund Freud believed was rigidly employed by people with anorexia nervosa is internalization. Internalization is the process in which the individual internalizes, in this case, the mother object, and then starves her to symbolically kill her. Hence, this process, ultimately defined as a disorder, specifically anorexia nervosa, is due to this complicated subconscious battle. By restricting caloric intake and symbolically killing the internalized mother object, the individual satisfies the id impulse, but still obeys the reality principle of the superego. She's not going to jail. That's how you alleviate that conflict. Of course, this process results in behaviors that themselves may reach clinical attention and a diagnosis of anorexia, but it's still not jail. Any movie in which you see a child attempt matricide or patricide, I want you to conceptually think is a symbolic expression of an eating disorder, specifically anorexia. If you look at the demographics, take it even one step further, any movie in which a daughter tries to kill their mother, symbolically, eating disorder. So is Carrie a fictional case of anorexia through psychodynamic interpretation and principles? Let's look at other aspects of this film to either support or perhaps rebut this. Next time I buy an extra large mask.
I don't think she wants to kill her mother.
It's hard to say, how does this movie end?
Oh, yeah.
Where does she kill her mother? In the kitchen. How does she kill her mother?
Nice.
Symbolic. Symbolic. There's another DSM criteria that the actual task force in 2013 removed because it wasn't quite as specific as we originally thought, but it still supports a diagnosis. What am I talking about? One clinical criteria that existed in the DSM-4 was removed in the DSM-5 due to the literature not supporting to be consistent enough, specific enough for diagnosis. However, if an individual has it, it does lend even further support that the single best answer is anorexia.
Generalized anxiety disorder?
No. It's the clinical criteria, the DSM criteria of amenorrhea. How does this movie start? Menzies in a 17-year-old. That's just primary amenorrhea. Yeah. So I don't think Stephen King put that in there, knowing that he was being very consistent with the diagnosis of anorexia.
Oh yeah, I was gonna actually just ask that. Like, did Stephen King know all this when he was writing his character, or was this just coincidentally it worked out?
It's coincidentally, and it took weeks, if not months, for me watching and rewatching this movie to come up with this. I mean, I'm not one who in the free time reads Freud, but in discussing this film and talking about it with people who provide psychoanalysis, they gave me a quick, hey, did you know? And, then a weekend was spent further expanding this to review again basic Freudian principles that will appear under exam. Do not think, I really don't think, that you're going to be asked about the internalized mother object and how eating behaviors that define anorexia are a manifestation of this inner conflict of wanting to kill your mom, yet knowing that you can't kill your mom. I don't think that's going to come up in an exam. If you go into psychiatry and if you become an analyst, if you want to actually go on and do a fellowship in analysis, it will come up.
Is there any chance, you don't have to go into it for time constraints, I know you said you're going to do it at some point, but that we can get that acronym for anxiety disorder?
Oh yeah, we'll do that. We're definitely going to do that.
Okay.
Okay. I'll even post it on Instagram.
Okay.
Absolutely. All right, so, Carrie, now the other thing I want to talk about here is that in the new millennium, we understand that there might be something beyond the idea that there is significant comorbidity with anorexia. That is, there are disorders that co-occur to the extent that there might actually be different manifestations of the same condition, and that anorexia may be a continuum illness. We already talked about one, post-traumatic stress disorder. Because of that common variable, because of that third variable, early childhood sexual trauma, many people conceptualize PTSD and eating disorder, specifically anorexia, as the same illness, but different phenotypic expressions. Dissociative identity disorder, also. Right.
You know, it's probably not like, obviously not always identified like PTSD with when someone that has anorexia, but like what percentage would you say, like in a person with an eating disorder like anorexia, that they have like some past trauma?
I would say 60 to 80%.
So I haven't watched the movie, just to be honest, but from everything you guys are talking about, it made me think of an eating disorder specialist I talked to, and she kind of described as an eating disorder manifesting because the person has like lack of control, and I've also read that anxiety is a manifestation of that lack of control, so they kind of like fit in this spectrum together.
Yep. Very important test-taking pearl. An individual comes in who looks like eating disorder may be the single best diagnosis. They are binging and purging. Single best answer?
Well, it depends on their weight, right?
Sorry?
Depends on their weight, right?
You can't tell, right? Be very careful. Binge eating and purging behavior does not differentiate between anorexia nervosa and bulimia, right? There is a binge eating and purging subtype of anorexia, and there is a binge eating and purging subtype of bulimia. So the binge eating and purging helps you zero. The other subtype of anorexia is called restricting subtype. And your patient may both binge eat, purge, and restrict. If that is the case, binge eating and purging takes precedent. If both, it's binge eating and purging. It's like saying, if somebody has bipolar and depression, no, it's bipolar, right? It's assumed to be part of the larger condition. Individuals with the restricting type of anorexia tend to have significant comorbidity with cluster C traits. They are the individuals who are very likely to be over-controlling as part of an obsessive-compulsive personality. They also could be avoidant. They could also be very dependent. Those are your three cluster C personalities. Binge eating, B, cluster B, right? Individuals here are very impulsive, which again is a very common trait for the cluster B personality disorders. And they could have other disorders of impulsivity, including substance use disorder. But again, if they take both.
That way.
Sorry?
I've never heard it described that way, but that makes a lot of sense.
Yeah. I try to make sense. It's one of the things I try to do. All right? I don't want to discount or underscore what many people watch this film and remember about Carrie Rowe. And that is, she has these episodes in which she dissociates and has special powers, including pyrokinesis and telekinesis. During those dissociative episodes, we would really need to know whether or not she has any recall of what she's done. And if something takes over her station, that is, something takes over her conscious awareness, rule out dissociative identity disorder. And certainly to the extent that we would explore this, it does fit with a history of trauma and perhaps a diagnosis of anorexia. Again, that continuum illness, because of that third variable of early childhood sexual trauma, perhaps at the hands of the very individual who is not in the film. That pertinent negative. All right, so that's Carrie White. For purposes of anorexia nervosa, the refeeding syndrome, which is a disorder of phosphate metabolism, is something you must be able to identify in an exam. It's when calories are introduced too quickly, resulting in multi-system acute illness, right? Including encephalopathy, congestive heart failure, and other related signs, seizure. So be able to identify the refeeding syndrome. Also, very common test question, when to hospitalize? When to hospitalize? Hospitalization should always be the standard of care for the symptomatic patient. Unfortunately, 90% of the time, you are going to have to remember the admission criteria in the asymptomatic patient. Always keep in mind the general rule of outpatient therapy failing. Well, if you have that in mind as really what your threshold should be, you should be able to capture when an asymptomatic patient should be hospitalized, right? So individuals who have significant electrolyte abnormalities, asymptomatic, that fail to be controlled as an outpatient is an easy example. Of course, any co-occurring condition that itself requires inpatient is a dead ringer. But generally, there's about 5 or so very common reasons to hospitalize the asymptomatic patient. All really do adhere to the failure or unsuccessful efforts to control as an outpatient. That includes poor follow-up, non-adherence with medication and treatment planning. One more clinical pearl. Well, actually, you know what? We'll talk about this one later. Remind me about the clinical pearl of choosing an antidepressant in someone with anorexia and co-occurring depression, say. The role of antidepressants here for a straightforward case of Carrie White, who we're not saying is depressed. Anorexia nervosa, binge eating and purging type, SSRI. SSRIs have effect on the binge eating and purging behaviors, whether they're in the context of anorexia or bulimia. If it's bulimia, non-binging and eating and purging subtype, or if it's anorexia restricting subtype, the SSRIs are of minimal value unless there's a co-occurring major depression.
Can you repeat that last thing you said?
Yeah. So while binge eating and purging behavior does respond to the SSRI, for the individual with anorexia nervosa, restrictive type, very little value. Similarly, bulimia nervosa, non-binge eating and purging subtype, minimal value. And the exception to the rule is when in each of those cases there's a co-occurring condition, major depression, that itself will respond to the SSRI. All right, we have about 15 minutes or so. What other film are we prepared to discuss?
Vanilla Sky? Vanilla Sky?
Vanilla Sky. What do you got for Vanilla Sky?
So when I was watching the movie, I noticed that it could be interpreted in many different ways. But I tried to look at it through the lens of this rotation and kind of the stuff you're looking for diagnoses. And I was thinking that the main character could be suffering from psychosis secondary to PTSD. And he's creating this world for himself, like in his jail cell after a psychotic break where he strangled his girlfriend.
Yeah, that's certainly something that is introduced to us, and what is reality.
Yeah.
And a lot of films, I think A Nightmare on Elm Street is probably the gold standard, are presented in such a way that the viewer has to decide what is sleep and what is reality. And this film is no different. And if you think that this might be more towards that side of sleep, and that what we're seeing is not through the eyes of an awake and alert individual, then yeah, might we think that what occurred at the beginning of this film, rule out murder, manslaughter, might serve as the setting where he becomes delusional, right? So I can't disagree. Certainly there's an element of psychosis here. Right.
I think another interesting aspect of it is that he could have like a TBI because he was in a car accident, and you kind of see that he becomes like, after that, he becomes like uninhibited. He's like drinking whatever he wants, he kind of just says what he wants, a little bit like explosive. His personality starts to change. So that is also another element that you have to consider, whether it's an aspect of a brain injury too.
I agree. You know, he has some personality traits that don't endear him to the seven dwarfs. But I don't think impulsivity is one of them. I think it's more of their thinking he's simply a spoiled child that grew up in these offices and really had no right being part of the group, much less their boss, right, the CEO, upon the death of his father. Following the traumatic brain injury, his behavior does appear to change. So, as a psychiatrist, you have to attribute it to the general medical condition before we begin to discuss mental disorders. In addition to general medical conditions such as TBI, any other form of organicity, the clinician should also consider before focusing on mental illness.
What was the major say? I didn't catch that.
Another example of organicity beyond medical condition.
Like drugs or?
Yeah, exactly. And I think it's evident here. It seems like, and I don't know if you've done this, but if you freeze the movie, he seems to be taking a lot of benzodiazepine.
Yeah. They show like little clips here and there of him taking pills, but you never know, they don't delve into it, so you don't know exactly what's going on.
Mm-hmm. I totally agree. I think this is a movie that might be complicated by benzodiazepine use. So when we're discussing this, the general idea would be, he looks like he's psychotic. However, for any mental disorder, psychotic disorders included, the clinician must first rule out that the behavior is not due to the direct and physiologic effect of a general medical condition and or a substance. And I think he has both here. This is benzodiazepine use disorder on top of traumatic brain injury, likely inducing psychosis. The reason why I wanted to bring this up, so the reason why I wanted to bring these two movies up, number one is because Carrie happens to share the same surname as Snow White. And I think, there's a way of linking these two films together as such. Similarly, because in Vanilla Sky, we're talking about the seven dwarfs. Vanilla Sky is about benzodiazepine use disorder. Might that inform us about what Snow White is really about?